We are not going to reconcile this at all. And we saw this just yesterday. We have how many of you in the audience were at the Diverticulitis Consensus Conference? Yes, so this is fantastic. Thank you for coming again. So this is exactly why we did this, is because we know there's significant controversies. Here, my disclosures are not relevant to this talk. So we know we have major rivalries. Rivalries are good for business, like Coke and Pepsi. They can be fantastic for entertainment value, especially when it comes to European soccer. And, of course, baseball and football in the US, and no question that when in the world of politics, they can be quite unreconcilable. But at least at SAGES, we can definitely reconcile our differences, as we saw yesterday. I think we had a really great crowd participation yesterday when we had our consensus conference. The surveys were already launched, both to the EAES and SAGES membership about 2 weeks ago, with over 750 responses. And yesterday we had another 194 responses. So this was really valuable. And this is what we saw. We saw actually a fair amount of concordance in the voting when it came to the recommendations that we essentially collected from the literature review using the grading system and standard recommendation assessment. And this is really where we're here today. So I just kind of want to go over the lay of the land when it comes to the guidelines that have been published over the past 10 years. There's this fantastic review that was just recently published that really puts it all in perspective. And you can see here very elegantly all these studies from around the world, really. There's actually 3 from the US, from the Surgical Society, ASCRS, but also the AGA, and the Family Practice Society. And you can see already the first point is that these 11 studies actually focus on different aspects of diverticulitis. Some of them focus on, you know, the classic things. You would expect acute uncomplicated diverticulitis and acute complicated diverticulitis. But then for the rest, it's sort of a mishmash of different topics. So some topics will tackle right-sided diverticulitis or diverticular bleeding, others won't. So there's already a lot of heterogeneity in terms of what they're actually looking at and what the variables they're looking at. And then to make things more complicated also, some focus primarily on diverticular disease, left-sided, and other surgical, primarily surgical aspects. There's lots of differences. The large majority of them are evidence-based, but others are consensus-based. And the one from the EAES was actually more focused on looking at the application of laparoscopy for emergency surgery. So it was not specifically focused on diverticulitis, but actually just in general emergency surgery. So again, lots of variability. What's even more important and relevant is that the quality of the evidence. We spent a lot of time yesterday explaining to you how we use a grade system for our consensus assessment. But you can see across the guidelines, they're using up to 5 different systems for grading the evidence, the quality of the evidence. And that really has an impact. And how does it have an impact? This is a really elegant way of putting it all together. When you can see here the color code, green is what you want. That's really high-level evidence. Yellow is moderate quality evidence, and red is poor, low or very low evidence. And then these different codes show whether or not there's agreement. You know, they recommend yes, first line, or no when it's an empty circle, and then somewhere in the middle. Where they agree, but sort of softly, selectively, or with limitations. And you can see even for a single topic, although they might even agree on certain areas, you can see that the level of evidence they're basing these recommendations is variable. They judge it differently based on which guideline is looking at the evidence. So there's tremendous amount of differences and heterogeneity, even in the way they're analyzing that data. And this is a cohort looking at a similar type of papers. This is only from 2011 to 2016. So the large majority of the published trials, of course, some of them were more recent, but they're essentially using the same cohort of papers. And you can see here, again, drawing the board, the different color schemes showing that they rated the evidence differently. Even more powerful when you look at, for example, the use of laparoscopy for elective surgery. Everybody agrees, mostly, but you can see, again, they graded the evidence very differently, either high level 1 evidence, high quality evidence, but there was at least one that actually graded it low. So it's very concerning and disturbing. Even more important, especially as we talked about, we're going to be talking about antibiotics, and Jason Hall is going to spend a lot of time on this. Again, you can see the wide range in agreement of whether or not patients should receive antibiotics on an outpatient basis. This really draws the point that we just cannot agree on this at all. A little bit more agreement when it comes to indications for surgery. So despite some of the things that we hear from the US, I think mostly all the guidelines agree roughly on whether or not when the timing of surgery should happen on an elective basis, although again, there's some differences in the level of evidence to justify these recommendations. This is just to show in the US, again, those 3 guidelines that were published over a short period of time, disagreement with the antibiotic situation, colonoscopy recommended after a single episode of uncomplicated diverticulitis. Again, the AGA agrees with ASCRS and does not agree with the family practice recommendations. Same thing with the antibiotics. You can see selectively, yes for ASCRS. And then same thing, elective resection after a single episode, as we just talked about. Same thing, no from the AGA, but selectively yes by ASCRS. So clearly, again, reflecting the conflict based on the exact same amount of evidence published, at least at that point. So here, if they're going topic by topic, I think it's important to see the major differences across the guidelines. Assuming concordance, the recommendations is achieved if 80% of the guideline agree with the recommendation. In terms of classification, for the good news is that there's actually good concordance. We all agree with what constitutes complicated and what constitutes uncomplicated. That's a win. We should cheer for that. Fantastic. It gets a little bit more muddy, obviously, when it comes to classification. Guidelines use different types of classifications, up to 4 different, actually 7 guidelines use the Hinchey-based classification, 4 use other systems. So we don't have a consensus on which classification to use across those studies, which is part of the problem. Risk factors, we do agree. We do agree across the board that obesity, low fiber diet, and physical inactivity are clearly linked to the incidence of diverticulitis. Immunosuppressions, NSAIDs with definitely an increased risk as well. So that's good. There's other risk factors discussed across the studies where there's a bit more heterogeneity, but for the most part, we do agree. When it comes to diagnostics, again, majority agree when it comes to the value of clinical examination, as we talked about yesterday with the consensus statements. A good physical examination and a clinical presentation is usually enough. And obviously, a CT scan for more complicated presentations is very sensitive. Everybody agrees. Ultrasound in centers with expertise is very good. So there's not too much discordance here. It gets a bit more muddy when it comes to whether CT should be preferred over ultrasound, because again, it depends on the centers. But this is largely driven by the lack of evidence for some of those recommendations. Moving along, and most importantly, we'll spend a lot of time today with Jason discussing this, I'm sure. Outpatient, we all agree that patients can be managed as an outpatient if it's uncomplicated. The problem is whether or not antibiotics should be given. I'm sure he'll discuss this. The guidelines cannot get along and cannot reconcile it. ASCRS and EAES recommended antibiotics as of 2014, but that's even in light of the AVOD randomized control trial they still did. And most interesting, as you know, presented yesterday, the Diabolo trial did confirm that there was no benefit in giving antibiotics. And after presenting this evidence yesterday, you still overwhelmingly voted for, please discharge my patient with antibiotics. Thank you very much. So clearly, a bit of a disconnect. It was really incredible. And we can discuss the reasons for, I'm sure Jason has his views on that. A little bit less controversial is, diverticular bleeding. Only 2 guidelines even tackled it, but at least no major red flags here. Secondary prevention, big topic of controversy, whether or not the role of probiotics, fiber diet, physical activity in preventing future attacks. A lot of discordance in the literature on this particular topic. As I said, more agreement in terms of indications for surgery. You can see overwhelmingly everybody agrees the patient is not doing well with effect of quality of life. The management of abscesses with IR drainage, fairly consistent across the guidelines. Laparoscopy, the role of laparoscopy overwhelmingly, especially in light of really good quality evidence. Technical aspects gets a bit more muddy, but for the most part, we agree on the basic principles. As we saw yesterday, all these guidelines the recommendations from the expert group did not have to be revoted on because there was overly agreement over 70% of all the recommendations. So to summarize, I think, as we'll talk about a little bit later, clearly the basing in on quality of life is really a point across all the guidelines. And then you can see here a little bit of deviation. The German and the Polish studies recommending elective resection for significant impairment of quality of life, 6 to 8 weeks. That's from the German guidelines. And then the World Society of Emergency Surgery resecting a bit more aggressive, suggesting early resection after IR drainage of a pelvic abscess. And I'm not going to draw the points regarding immunosuppression because our next speaker will discuss it. But again, laparoscopy, some discordance in terms of whether or not it has a role in emergency surgery. The same thing with some discordance in terms of what defines a large abscess that is amenable to percutaneous drainage as opposed to not. Some discordance in this a little bit. Laparoscopy, still pretty controversial. Some guidelines recommend laparoscopy in almost every case, at least try laparoscopically. 2 guidelines recommend it only in selected cases. And then the Polish Society only in highly experienced centers in the cases of Hinchey 3 diverticulitis. So I'm sure we'll spend a lot of time on this. I don't want to impinge on what the next speaker is going to discuss, but clearly you can see the tremendous evolution in recommendations when it comes to complicated diverticulitis, complicated presentation with purulent or feculent diverticulitis. And this is obviously a lot of it has been largely influenced by the randomized control trials. But you can see here, lavage is no longer recommended after 2013 in those guidelines based on that emerging evidence, with definitely resurgence of recommendation of Hartmann's or at least a diversion. And damage control, which I'm sure we'll discuss at some point as well. So clearly, this is my last slide. We have major discordance. There's no question we'd like to believe that it's because we have low level of evidence to explain and to justify those recommendations, hence the discordance in the agreement and recommendations. But the problem that we find across the board is that the guidelines are weighing the same studies in literature differently. Whether they classify it as low, moderate is an issue, and clearly it blurs the lines. And this is a classic example, obviously, knowing that there's something else going on, is, the AVOD and Diabolo trial are very much supportive of not using antibiotics as an outpatient management for uncomplicated diverticulitis, and yet it has not affected recommendations or practice, as we saw yesterday. So clearly the role of clinical judgment and standard practices and local practices and maybe the medical legal environment may play a major role that we're not capturing in those guidelines and should be explored. But at the same time, we saw very nicely that agreement can be reached in the absence of low level of evidence. So that's reassuring. For example, surgical technique-based strategy and what you resect and how, and that's helpful. I think a couple of people in the audience yesterday made excellent points that we're going to be taking back to our expert group. Is clearly we also are not taking into account an evolving demographic, the demographic of the young and obese patient with a very complicated first presentation, and whether or not we should be using other criteria to guide their elective resection. Thank you very much.